like to introduce tonight's speaker now, Dr. Jason Burnette. He earned a Bachelor of Science degree in Urology from Augusta State University, where he graduated magna cum laude. He earned a dual MD, PhD degree from the Medical College of Georgia in Augusta, where he also completed a residency and served as chief resident in his final year. Dr. Burnette is board certified in urology and a fellow of the American College of Surgeons. He practices at Urology Associates of Archbold near Thomasville. And y'all help me welcome Dr. Burnette.
Well, thank you very much. It's good to see you all. Know a lot of friendly faces out here that I've seen recently and some that I've never seen before. Not going to call any names out here or anything like that. So again, like I said, this is going to be a very kind of informal talk. And when they asked me to put this together, it's something to do with men's health, and I know how hard it is pulling men into the doctor's office. It's been difficult, and some of the guys I have come in there, they're kind of in kicking and screaming, and hopefully my goal is to make it as easy and harmless as possible on them so they want to come back. And when we started talking about men's health, there were a number of things that I commonly get questions asked to me, some other things that I like to talk about in terms of screening and prevention, some hot topics that have kind of been out there, you know, that the news and media, they go against. And anyhow, maybe we'll answer some questions, clear up some confusion, and go from there. Let me see. Disclosures, I have none. I'm not getting paid for this. I'm kind of just doing it so we can sit here and kind of have a fireside chat almost. And disclaimer, I had a lot of nudie pictures in here, and apparently they've all been taken out. I'm kidding, I'm for real, but anyhow, all right. If I get off track too, by the way, y'all reel me back in. Just tell me, hey, you're kind of going a little bit too far out. So thanks, Ashley, for the introduction. I'm a Georgia boy. Just a little bit about myself. I grew up in Northeast Georgia, spent 3.5 years in the military. When I got out, I landed at Augusta, Georgia, spent some years there, and then just stayed for a while. And I've been here now for about 8 months in Thomasville, and absolutely love it. I tell you, not any finer people that I've ever seen in my life than the ones down here in Southwest Georgia. So thank y'all for welcoming me with open arms. Well, you know, we hear so much talk about healthcare in America, how far we're behind, how healthcare in England is so good and Canada is so good and all this other stuff. Well, the bottom line is we must be doing something right, because if you look at the average life expectancy of the U.S. male, we've gone from 47 in 1915 up to about 80 100 years later. So the average life expectancy, we're doing something right. And there are a combination of things, whether it's healthcare, whether we've come up with better drugs, better diagnostic modalities. CT scans have kind of bloomed. We've got better tests, immunizations, you know, coming up with the polio vaccine, coming up with penicillin and other things like that, antibiotics, pesticides. You know, we don't hear people dying of malaria and diarrhea and pneumonia as much as we used to. And those, again, 100 years ago were probably the top 2 or 3 killers of men and women. We've got clean water, and again, with just a few little bumps here and there, we've had a lack of wartime events. But again, our cancer system here in America, we're performing well, and even things that I don't deal with breast cancer, 5-year survivability and 5-year survival rates are the top in the world. Above Japan and everyone else. And if we looked at colorectal cancer, we're number 2, and that's just behind Japan. So again, we're doing a lot of the right things. I think we could do better. But again, as men become more willing to go to the physician, as the wives drag them out there, and as men, and they are doing this as well, they're becoming more actively engaged in their health care, I think we're going to even get better. So, you know, a lot of people say, what can I do to live longer, Doc? Can you tell me how am I going to live longer? And there are a lot of different factors. I mean, some people are just blessed with a healthy gene pool. I mean, parents live to be 90 and everybody in the family lives to be 90, and that's just a lucky family. healthy diet and exercise, routine health maintenance, just getting checked out every now and then. You know, it really breaks my heart to see that we're so advanced here in America, and then I probably have 5 or 6 patients that come to me a year that have not been to a doctor in 40 or 50 years. And it's just sad. And then it's a domino effect. You find one thing wrong with them, the next thing you know, they've got high blood pressure, then they're diabetic, then they're eat up with cancer or whatever else, and it's really sad. Vaccinations, I'll give you my 2 cents on vaccinations here in a little bit. I like to tell all my patients everything in moderation. I deal with a lot of things such as kidney stones or whatever else, and the question is, do I need to stop? Do I need to stop drinking coffee? Do I need to stop drinking tea, sodas? No. But again, you don't probably need to drink a gallon of Mountain Dew a day. You probably don't need 8 or 10 or 12 cups of coffee a day. So everything in moderation. We'll mention smoking because it does lead to a couple of illnesses that are urologically significant. And then again, routine screening, a lot of it that we have, you know, especially prostate cancer screening in the aged male, it's come under fire over the last 10 years from the United States Protective, Task Force, Preventive Task Force, saying they don't recommend it, now saying they do recommend it, to where are we at now with it? So like I said before, if you look at studies that deal with, this was based off of Ashkenazi Jew population, but there is subsets of these folks that live 95 to 105 years of age. And they've seen that some of these people have homozygous genotypes, where they have adipocyte gene deletions and other type gene deletions, and we end up seeing them live to be 95, 100, 105 years of age. So we know that genes have something to do with it. Again, healthy diet and exercise. I believe this talk was last week, where we kind of talked about how to eat right and all that stuff. I will say that I've been pleasantly surprised here in Thomasville, for a town of its size, to have just such great places to eat. It's wonderful. I don't think you'll find a town of this size with this many top-end restaurants anywhere, unless you, like I said, and go to Atlanta or whatever else. But again, routine health maintenance, I'm going to talk a little bit about that, and I'm going to actually break it down age specific. So what we should be doing for our grandkids. Good thing is I don't see any young kids in here, because most of the talk not for them, but I'm sure y'all have grandkids or know people that have small children, and some things maybe they should be doing to kind of keep the ship right. Also, we'll talk about things to do as an adult and as you move forward into the twilight years. Again, vaccinations, that's come under fire. As a society, we tend to kind of put a little bit too much trust, belief, and faith in movie stars and people that are on the TV, and not in science. And we had someone like Jenny McCarthy for years bashing the whole vaccination thing. You shouldn't get your kids vaccinated. Her kid is apparently autistic, but I think things that they missed telling were the fact that she had sat in a hot tub while pregnant and had some other risky, but she was a smoker or whatever else. And so they tried to link it to vaccinations, but again, if you look at the scientific data, from 2007 to 15, they prevented 152,000 illnesses based on vaccinations and almost 10,000 deaths, with zero people receiving vaccines linked to autism. Influenza vaccine. Here's another one that I hear a lot about. Every time I get the flu vaccine, it makes me sick. Well, it probably makes people feel a little bit bad. It's not a live vaccine. The few live vaccines we used were years ago, the polio vaccine, so we could gain herd immunization. You would end up sloughing some of the polio off, so we'd get herd immunizations. But these are killed. We have other ones such as Gardasil from the human papillomavirus. So that's another one coming down the pipelines for boys and girls to prevent cervical cancer and possible penile cancer. And again, what's next? I mean, I think we're starting to see a trend toward immunizations. I foresee in the next 50 years, we would have an immunization for men at birth that would basically eradicate prostate cancer. We already have an FDA-approved immunotherapy to treat metastatic prostate cancer. And so everything's kind of working toward that pathway. So again, I said everything in moderation. I love this quote by Oscar Wilde because, I mean, really, everything in moderation, including moderation. On the right, you'll see a kidney, and this was from a patient who had drank, a dozen sodas a day and finally ended up getting severe kidney stones. So again, you don't have to drink every soda you see. I tell my guys and gals, just, for every soft drink you drink of water. Something simple. Watch your red meat consumption. Don't stop it completely because, I mean, you can't live in a vacuum. You can't live and be so miserable it ain't worth living, but everything in moderation. We also talk about bladder cancer. Unfortunately, they edited out one of the other pictures here, but smoking is correlated with some of the urologic cancers that we see. In bladder cancer, which is, you see a picture there, that's what a typical bladder cancer looks like. This is the inside of a bladder, and if you think about looking at like on the inside of a ball, that's where they start out. And tobacco abusers are 3 to 4 times more likely to get bladder cancer than non-smokers. I mean, I do see it in non-smokers, but just having to do the battle with someone who has smoked and then develops bladder cancer, and it can be a little bit difficult and taxing. Again, age over 55, white males tend to get it more. We also do see a higher prevalence in textile workers, and textiles being prevalent here in the South, people are exposed to different dyes. So that's something to also think about. And people who've had chemotherapy, some of the old chemotherapies in the past that they used, if not used with other alkylating agents, leads to hemorrhagic cystitis and development of bladder cancer. Penile cancer, very curable cancer. We'll talk about that in a few slides, but it's not a common cancer, but we do see it in men. Usually they've had HPV, and again, we talked about Gardasil being one of our immunizations that we have out there. Again, men not being circumcised at birth, and there's a difference. A man that gets circumcised at the age of 50, 60, 70 probably doesn't have that protective effect that the ones circumcised at birth do. Again, being over the age of 60, having phimosis or narrowing of the foreskin, poor hygiene, many sexual partners, and again, tobacco use. Usually the ones I've seen in the past end up being a tobacco abuser and being uncircumcised. So some recommended screening, and we already do a lot of this stuff, but for most of my guys that come through, especially the younger guys, as well as moms that come through and have young children, I tell them a monthly testicular exam should be performed. Usually when you go to your primary care doc, they normally get a urine specimen on you, so you're getting, whether you know it or not, a yearly urinalysis. And again, blood in the urine is what we look for. It's usually linked with something possibly like a kidney stone or an enlarged prostate, sometimes infection, trauma, tuberculosis, and tumors. So that's kind of the thinking behind our minds whenever we get sent a patient with blood in the urine. Digital rectal exams annually. You missed that one. See, I snuck that one in on you there. Annually, starting at age 55. Now, we kind of bumped out the prostate screening ages. Used to, we screened earlier. We started around age 40 once we developed the PSA assay. But now it's usually recommended age 55. I'm going to talk a little bit more about that later. Ultrasound and abdominal scan imaging starting at age 16 for patients or families that have von Hippel-Lindau. These patients end up developing different tumors of the body, renal cell carcinoma of the kidneys, different type of eye manifestations, and cerebellar manifestation. Also genetic testing for these families. And now the PSA or prostate-specific antigen screening, it's recommended in men 55 to 70. It's a blood test, not a semen test, not a urine test, none of that. It's a blood test. We like to have that value less than 4. In men, pretty much over 60. There's a little bit of leadway in guys 55 to 60. Again, we like it usually under 2.5. And I recommend that we start screening earlier in men who have a first-degree family member that's had prostate cancer. And the first-degree family member that we'd be talking about is either a dad or a brother. And usually I tell them whatever age they were diagnosed at least start 10 years before, or around the age, 45 to 50 is probably a good time to start.
Your first test there, what are you looking for? Bumps or what are you?
On the testicles? Yeah, lumps or bumps, anything like that. Make sure they're developing normally. I hope I've got a picture here. It's just little subtle changes. But men that do the monthly self-testicular exams, they'll find, or they'll pull little things out, and sometimes I can't even find it whenever they come in, but they have a concern about a new bump, knot, or something like that on the testicle. Again, Caucasian men, most of the studies done were Scandinavian studies done over in Norway and Sweden. They were looking at prevalence of testis cancer. But yeah, a little bump or something like that. And then this is also going to segue into another thing in a few slides that affects boys as they get older as well. Any other questions from? Yes, go ahead.
Did you say the VHL families?
Von Hippel-Lindau. So it's a gene mutation on chromosome 3. It's associated with the VEGF, and it basically puts these people at a higher rate of kidney cancers. Go ahead.
Why is the PSA not recommended over age 70?
That's a good question. That's one you really got to play by. It's a little Kentucky windage. I think you got to use a lot of common sense. If I have a 70-year-old guy that comes in and he looks 50 or 40, and I have quite a few of them, I say, you probably want to keep screening. You look like you have a lot of life left. Looking at the average male life expectancy, we know that death from prostate cancer usually would take 15 years if untreated. So based off projected mortality rates and ages, that's why. I occasionally get 84, 85-year-old men that come in, and it's tough because they're used to the old ways of screening. They've had a PSA every year, and as a matter of fact, they can sit there almost like a computer and tell me every PSA they've had from the age they were 50. And I think you got to use a lot of common sense with it there too. Definitely a 70-year-old man that walks in there, or even a 65-year-old man, if he walks in with one foot in the grave and one on a banana peel, prostate cancer is probably not going to be something that you really need to actively look and poke and prod for. But again, it's all using a little bit of common sense and discretion. But this is just based off pure guidelines. As a matter of fact, our government, without having a urologist on the panel back in, this was 2008, said no more PSA screenings. And the American Urological Association said this is ludicrous. You didn't have a urologist on your panel. You're making up screening guidelines because we're doing a better job, and the death from prostate cancer is going down. This is not coincidence. And they came back and they kind of redid a little bit of their screening. So.
False positive for that test?
So I tell folks whenever it's elevated, it's not prostate cancer selective. If it's elevated, there are a number of things that can make the PSA go up. It can be elevated because it just so happens you've got a huge prostate. It's a BPH, benign prostatic hyperplasia. If you have prostatitis, inflammation, infection inside the prostate gland, that can make it up. If you've been recently instrumented, been in the hospital with a Foley catheter, and then somebody gets a PSA value, it will go up. So I don't really say false positives, but again, I usually take PSA values, not really with a grain of salt, but I do that in conjunction with a rectal exam, because if you feel back there and on digital rectal exam, you can actually feel the posterior aspect of the prostate gland. And so sometimes you feel back there and you feel what feels like a cancer. So that together, sometimes I get a % free PSA. And they had a study in JAMA back in 1999 that actually showed there was a high correlation between men with a low percent free and developing or having prostate cancer. So that's how I kind of do it. Now, I have a guy that comes in, say, that has a PSA of 7 or 8. And we've done the workup and we've done a biopsy, and his prostate gland, which should be historically 15 grams, size of a walnut, it's 100 grams, just due to genetics. And his PSA is 8, and we've done a negative biopsy and everything. His new PSA resets at 8. And we don't try to chase a lot of stuff down. So, I mean, why is it important? I guess that's the big question. It's important because if you look at articles from the Surgeon General, they've shown that, you know, if we can do tobacco prevention and screening in folks, we could save $3.7 billion a year. That's a lot of zeros, okay? A lot of zeros. And you know, the sad reality is Social Security and Medicare, I mean, they're running out. If you look right now, based on recent studies, and this is from the Chicago Tribune, I mean, it's saying that Medicare could be insolvent by the year 2026. That ain't long. Not to scare you, but that's a fact. If you look at Social Security, they're saying it's going to be insolvent by 2034. That ain't long either. I mean, this is a fact. So what we do know, early diagnosis, I mean, look at the World Health Organization. Early diagnosis equals better outcomes. Usually we're screening, if we screen quick enough, we find lower grade, lower stage cancers, and we're able to actually offer a lot of less invasive treatment options to these folks. So, and again, you look at cost in medicine, huge cost, drug cost, chemotherapeutic agents. I mean, you talk about some of these chemotherapeutics. I mean, I talked about the prostate cancer immunotherapy. It's called Provenge. I mean, it's $90,000 a month. And I mean, we're only talking 6-month survival advantage off not doing it. However, if I had it, and you know, if it was going to make me live 6 months longer, you know, I may have to think twice about it too. You know. So I got in. I wanted to talk about some recommendations because I hear these come up a lot. Did a lot of pediatric urology in Augusta, and then I was in private practice for a number of years. Didn't do a lot of pediatric urology there, and now I've started back doing it. And one of the big things I'm starting to see now is newborn males, and whether or not to circumcise them. That's been a hot topic. If you look at the American Academy of Pediatrics back in 2012, they had a huge push not to circumcise. And again, being in the urology field, we ended up we had to field a lot of these questions. And the funny thing is like literally within a few years, the same group that said don't circumcise also did a study on children in Africa. And it actually showed that it lowered the risk of developing HIV and other sexually transmitted diseases in heterosexual partners. We've known for a fact that the only men that develop penile cancers are men that were uncircumcised. I mean, that's it. So from our standpoint, you know, we do say, hey, it's the parent's choice. If you're hell-bent on not circumcising your child, well, that's it. You've made your decision. You know, we ain't gonna twist anybody's arm, but we do know that it does prevent disease transmission. And the American Academy of Pediatrics also taken a softer stance on it. They just said the benefits of circumcision don't outweigh the risk. There's very little risk associated with it. Boys do a lot better when they have it done in the neonatal period. And again, locker room appearance as well. I mean, you know, you just got to think about that. One time you would not do it is if a child was born with a hypospadias. I had a picture of it here, but unfortunately it was taken out. But hypospadias is where the urethra opens up on the underneath aspect of the penis. So the opening is not at the tip like most men are accustomed to. it's down somewhere on the underneath side. That's one time you would not circumcise. Usually end up waiting to the child's at least 6 months of age, and they undergo a corrective surgery if needed. I will mention hypospadias. It does fall into an intersex category. This discussion tonight is nowhere near what we're going to talk about. We're not going to talk about intersex or disorders of sexual differentiation. I will say that again, hypospadias, men wouldn't circumcise them, and I would also make sure they've had an appropriate testicular exam. A hypospadias male with an undescended testicle needs to have an intersex workup. That's bottom line. We actually had a little, it was a little boy initially, and they were happy. Dad was ecstatic about it. You know, he had his little boy. It was a Hispanic family, and needless to say, had a hypospadias. Ended up getting the workup, and the little boy was a girl. Had congenital adrenal hyperplasia, which caused basically higher levels of testosterone in the female child. So the female parts began looking male-like, and they had, that was huge kind of conversation with the dad. He was heartbroken and all that stuff. Then they ended up getting her adrenal issues squared away and raised her as a female, which she was. So transgenderism and all that stuff, another big, long, new topic. We're not going to get into that here. Again, it goes down to testicular exams. Again, make sure you're feeling down there, make sure the testicles are down, make sure we're screening for testis cancer, because it doesn't make you a cheater. That's Lance Armstrong, by the way, so if y'all didn't recognize him, but he had testicular cancer, was actually treated for it, and then won fraudulently a number of Tour de France. So again, as you get into the teenage years, the teenage male, again, not a whole lot to do from a urology standpoint, but again, continue the monthly self-testicular exams. Because again, you see here in the illustration, a normal testicle versus one with a tumor, they're going to probably start out small. And it's going to be something that they feel just because it's something new there. We try to get these out surgically, remove the testicle, get them out as soon as possible. When you again, early treatment, better outcomes, you get the T1 testis tumor, usually you don't have to have chemotherapy for a lot of them. But if it gets to T2 with lymphovascular invasion, or T3 or spread elsewhere, then you're looking at chemotherapy, and then the child may be infertile. Testicular torsion, this is another one where the testicles in the male, they form up near the adrenal glands. And as the child progresses through as an embryo, they come down and they drop. And the kidneys actually form way low in the pelvis, and they come up to their resting spot just below the adrenal glands. Sometimes when men are born, they don't have the correct attachment. The testicle doesn't attach down into the scrotum, and they can get what's called a Bell's Clapper deformity due to just an absent, what they call gubernaculum. And when it doesn't attach, the testicles, again, they have muscles on them, cremasteric muscles, that make the testicles descend or rise because the production of sperm is temperature dependent. So they rise up and down all throughout the day. I mean, jump in a cold lake, jump in a cold swimming pool, and those things, you can't find them, you know. Well, in these boys that don't have that attachment, they can twist, and they can get what's called a testicular torsion. That is a surgical emergency. And the reason I point it up is you know, if you got daughters out there or you got grandkids, don't be afraid to examine them, and let them know that it's okay to examine them, because they're going to hit an age range that they're embarrassed, and it's sad to see a young man that's had this for 2 or 3 days, and they come into you and the testicle's dead, and you have to actually take it out. Something that could be fixed. You have really just a 6-hour window, and again, it'll spin around on itself. I had a nice picture illustrating how it will actually spin around on itself, you know, 360, 720 degree spin, and the testicle, it'll be completely black, okay? We do get scrotal ultrasounds. That's one of the first things while we're trying to get everything going, and then we take them to surgery right away. That's the thing. If there's a question of it, let's get an ultrasound if we can. If it's going to take an hour or two and we clinically suspect a torsion, they go straight to the OR. So in the 40-year-old men, now a lot of questions about 40-year-olds, vasectomies. I get a lot of guys low testosterone, and what do we do with all this kind of stuff? And you know, I do tell them, well, the vasectomies, you look at this as a permanent treatment. It's a relatively inexpensive procedure to have done. Reversal is very expensive, and it's not guaranteed. Some people charge up to $12,000 for a reversal without a guarantee. Some men have post-vasectomy pain syndrome. That's usually in less than 1.25%. It's a quick procedure. We do it here under just some local anesthesia. It can be done under some twilight sedation. Men do very well from it. Years ago, they thought it was associated with prostate cancer. We know now that that's not the case. There was a correlation, probably because they were screening these men for prostate cancer just because they were going to a urologist. And we had a new test, and of course, everybody got it. Low testosterone. I hear a lot of talk about low testosterone. Let me kind of explain the normal physiology of testosterone. If you remember back when you were in your teens to early 20s, you had that spike in the morning, felt great all day, even after noon. You may have felt a little bit of a drop in energy, but around 5 or 6 o'clock, then you had that second spike of energy. You could go out, go to the juke joint if you wanted to, you know, and stay up late at night and then get up, you only sleep 4 or 5 hours, and you did great. Unfortunately, when men get over 40, we kind of go through a menopause of our own. We're just not grumpy. I'm kidding. Where we lose that second spike of testosterone in the afternoon, and that's when I hear a lot of guys say, Doc, you know, I'm okay in the morning, but afternoon, I'm dead. And I get home and I get in my chair, that's it. And I get in the recliner and I take a nap and I ain't worth nothing. And so you lose that evening spike of testosterone. I will say this, if you look at having testosterone replaced, just make sure you do it safely and correctly. Again, recently there have been some black box warnings on testosterone. We found that there were some men on testosterone replacement that were having heart attacks, cardiovascular events, etc. I'm not sure if it was due to the testosterone or just due to the simple fact that for many years they had been just couch potatoes, and finally they had the energy to get up and they were finally doing stuff, and they felt good enough finally to carry on with their life, and then it precipitated it or what. But I do recommend PSA screening for all men on testosterone replacement before and during. We know that men with prostate cancer, if you start testosterone replacement, that can accelerate the growth of the prostate cancer. Blood counts. You know, there is the chance of getting very thick blood, what we call polycythemia, stroke, heart attack risk, things of that nature, blood clots. Check testosterone levels. You want it within a range. I mean, I have some younger guys who feel that if their testosterone level, and the normal range is about 300 to 800, but they feel that they need their testosterone, you know, 1,500 to 2,000, and that's not right. All they're doing is exposing themselves to other things. So make sure you kind of follow those ranges there. Metabolic panels, part of the biosynthesis pathway for testosterone is through the liver. And again, look at the hormones that are produced by the brain that cause testosterone to be produced, such as luteinizing hormone.
Does low testosterone have anything to do with vasectomy?
Not if they accidentally take out all the blood supply to the testicle and you have an atrophic testicle, it could. So you have three.
It's been quite a while.
Yeah.
I doubt if there was anything particularly wrong with the operation, so
you know what you see is with the testicle, we have 3 blood supplies. So you have your cremasteric arteries that supply, you have a testicular artery and the deferential artery. But we're thinking with a vas deferens, when you ligate it, it's just the deferential artery that gets taken there. So 2 other blood supplies to it. Not to, I mean, I have seen guys that have had vasectomies, not by myself, knock on wood, and they come in and one testicle is atrophic. I see all my guys back after vasectomy at a 6-week mark as a courtesy visit, just to make sure testicular size is felt, palpated, we're not losing loss of testicle. So, again, prolactin's the last thing on the list there. There are some prolactin secreting tumors in the brain. I've found 2, I think, in 5 years. So I check that routinely.
Is there anything that encourages testosterone production in the body? Can you do anything about that to increase your own?
To increase your own? You know, they say diet and exercise. That's where a lot of the new data is coming out. There are some, there's some pills I've treated guys with in the past called Clomid. We usually use that for females for ovulation, but really nothing now has come out. I know they sell stuff like Nugenics. We'll sell some testosterone boosters, a lot of things over the counter that claim to boost testosterone. Most of the studies I've read, diet and exercise probably going to be it if you're going to get any boost. The sad truth is just a lot of guys get testicular failure, or they're just not having an LH spike anymore. And really treatment's the same, whether it's your brain's not telling your testicles to produce it or your testicles have failed. So, in the aging male, a couple of things that we will run into. BPH, if you look at men, half the men over age 50 ends up having issues with voiding. We didn't experience this back in 1915 because I told you the average life expectancy then was 47. Now men are living longer, and again, as you get older, and guys that have seen me routinely in my office, I tell them straight up, as you get older, everything shrinks, but your ears, your nose, and your prostate. And that prostate will continue to grow. The good thing is now we've got medications to start guys out on. The bad news is every man's heard the story from their grandfather about how he had a Roto-Rooter done years ago, and it was the worst thing he's ever had done. He bled like a stuck hog, and my goodness. And then they had to have it done again. But we have great treatment options. We have pills. We have open surgery. This is what the benign prostatic tissue looks like if you enucleate it out. And it's that prostate tissue that sits around the urethra or the urine channel. We have a newer treatment called UroLift, where it's a less invasive surgery than actually doing the TURP. That I love it when people refer to it as the Roto-Rooter, but it's a newer procedure. It seems to have good data and good support behind it. And again, prostate cancer screening. Recommend that we do a PSA yearly. Some people say every 2 years. Again, if it's really low, I think that would be fine, but a yearly PSA, as time passes, the tests, the reagents, everything gets cheaper, and a digital rectal exam. And again, the big question is, do you stop at the age of 70? I have guys, if I pick up folks who have been sent to me for screening, health care, health wellness, and they've had PSAs and they're 75 and they come to me and that's what they've had and they want to have it done, then do it. I mean, you can't put a price on peace of mind. If it's an $8 test, to be frank with you. But again, at some point in time, as they hit the 80 or the 85, I'm like, listen, why are we even screening for it? Because if we found it now, what would we even do about it? And so you have to, then you talk to them about that. Again, go ahead.
You listed pills there. What are the advantages or disadvantages of the pill?
Mm-hmm. The pill versus surgery or whatever else?
Well,
or each pill.
Yeah, each pill.
All right, so we're going to get into the treatment here. And you'll hear a lot of different medications. And as a matter of fact, they started out years ago, they saw a correlation in men on alpha blockers, Cardura, for blood pressure. And they had improvement of their urinary symptoms. I don't use those medications anymore, the older ones, because they're non-selective. Now we have more selective alpha blockers that really just work on the prostate. We have a number of different pills like Flomax. Flomax is probably one of your older ones out there. The thing is, it's generic now, and I like it because it's cheap. And it's usually, so advantage, cost. And a lot of guys, I start them out on Flomax, and then they say, well, it's working, but I need a little bit of something extra. And then I double them up. I say, we'll take 2 of them. And that's one of the common practices that we've started. Now, some people do have lightheadedness, orthostatic hypotension, they have retrograde ejaculation, and they want to get off the medications. Rapaflo is one that they say if you've got a guy on 2 Flomax a day, then maybe step them up to Rapaflo. It's probably a stronger one that's just come out. If you look at its selectivity for the prostate receptors, it's a lot higher than Flomax. Your Roxetrol is somewhere in between. Sometimes you just got to play around with the medicines on them. I have another one there called Avidarts, dutasteride, and finasteride is its generic cousin. Those are for shrinking the prostate. So I typically say, and based off BPH guidelines through the AUA, the prostate needs to be at least over 30 grams, so twice the size a normal prostate would be. Then you can start something like dutasteride or finasteride. You get, on average, a 10 to 15% reduction in size of the prostate gland. The side effects of it, though, let's talk about it. So dutasteride and finasteride block 5-alpha reductase. When you break testosterone down, it goes to dihydrotestosterone. That's the active male form. That gives you your male characteristics. That also is what works on the prostate gland. So you block it, that testosterone has to go somewhere else. It gets converted to estradiol through aromatase, and then you can see breast enlargement in men. So you can also see a little bit of hair growth as well. In some of these medications, some of them are people take like 1 milligram of the finasteride for hair growth. These play around with some of your PSA values. Any man that's on finasteride, regardless of the dosage, I normally double their PSA to give myself an accurate reading of it. So that's something else you have to consider. I try to stay away from the Avidart or finasteride if I can, though. They irreversibly bind. Some men have sexual side effects. I don't know if it's psychological or if it's true, but you have to play around with them. But most of the time, I have to consider a lot of things when I'm treating folks, and cost is one of the big things. I mean, if you can't afford the medication, then the prescription is not worth the paper it was written on. So we start out usually the cheapest way and work our way up.
Does the enlarged prostate restrict urine flow?
And that's another good question. So right here on the bottom, again, you talk about the Roto-Rooter, and it is carried out by basically putting a metal scope into the penis and cutting away prostate tissue. If you look on the right, there's a diagram, and at the top of it, let's see if I've got a pointer here. Right here's where the bladder would be. This is prostate tissue, and this is the urine channel right in the middle. And again, as the prostate grows, it restricts that urine channel. So I tell guys, usually you start out in your 20s, and it's like you're peeing through a garden hose. And then you hit your 30s and 40s, and it goes down to like a straw. And then by the time some men get in their 50s and 60s, and as you can see here, I mean, this is like a coffee straw here. And it can cause significant health issues. Men can get infections. They can have bladder failure. The bladder is not just a bag. I mean, it is a muscular ball. And over time, if you block something, just like if you block your heart, over time it's going to wear out. Game over. The bladder, over time, it can wear out. It can develop different things there, diverticulae. It can stop working, stop squeezing the urine out. You can get bladder stones. It can get so severe that you also block your kidneys from working properly, and you can go into renal failure. So there are some reasons to treat. Those are the indications. I just gave you all those. But yeah, as you get older, you're going to see the stream kind of weaken and all that stuff. And like I said, the good thing is we can fix it. In some men, we can fix it at $4 a month. I do hate to see guys that get on this saw palmetto and super beta prostate, and they'll spend $30 a month for some of these medications that have not been FDA evaluated and FDA approved in any way, shape, or form. They don't have to be. Flomax, it has been. We know the exact mechanism of action. You know, it relaxes smooth muscle in the prostate. We've seen it do that. Saw palmetto, yeah, I don't know. You know, some people, they swear by it. They swear by horny goat weed. You know, some people walk on hot coals too. I'm not going to do that one. But kind of last but not least, we'll talk about erectile dysfunction, sexual health in men, and it's important. I tell you what, in my opinion, there's no greater bond that a husband and wife or a man and his female counterpart can share than you know, sexual health and just bonding. And if you look at it, it's very common. You know, in Europe, in the UK, they say 1 in 10 men, and I'll show you some data here in a minute that actually shows you maybe 1 in 5 in the US over the age of 20 suffer from erectile dysfunction. If you start looking at men over 40, almost 40%. And if you look at men at 70, 67% of men have some form of erectile dysfunction. So it's pretty prevalent there. There was a great article that came out back in 2012, 11 or 12, and it was in one of the journals of psychiatry. And they were actually looking at depression scores, and it was based off of heterosexual college women up in New York. And they basically demonstrated that with females in a monogamous, healthy sexual relationship had lower depression scores than other women that weren't. They actually showed that it eases pain just due to the endorphins. Eases pain, cardiac health. Maybe it helps there. I mean, it's a good workout. Decreased risk of prostate cancer. I still think that the jury's still out on that. They say it may help heal wounds and fight aging. And this was a real controversial topic. At the time, Lazar Greenfield was the chairman of the American College of Surgeons, and he made this comment. So there's a deeper bond between men and women than St. Valentine would have suspected, and now we know there's a better gift that day than chocolates. He actually got relieved of his duties there after something as benign as that. We've really gone very politically correct in this world. But again, it's, you know, I have a lot of guys that come in. I'm going to talk, I'll give you a story here in a minute, but a lot of guys suffer from it. And I hear a lot of men come in and say, well, you know, my doc told me that I'm just old. And I'm like, yeah, okay. I mean, that don't mean give up. I mean, that don't mean throw in the towel there, you know. So, you know, I define it, and it's defined by the AUA as the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. So it has to meet one of those two criteria. Again, we're finding it a little bit higher prevalence. So almost 20% of our men over the age of 20, and that comes out to about 30 million American men. And again, I had a guy come in last week and he said, look, I said, do you have erectile dysfunction? He said, yeah, but my doc told me that's because I'm old. And I said, well, listen here. I had a gentleman, I was in Augusta, one of my last years there in training, and he was at the VA, and he was 85 years old. And I mean, he had commercial insurance and all that stuff, but he went to the VA. That's where he wanted to go. And he said, I want to get treated for erectile dysfunction. I've tried everything. And I said, well, why? Why is it important? He says, well, you know, he goes, honestly, I ain't got that many more years left on this earth. He said, I just want to make love to my wife one more time before I die. And I said, okay, fine, you sold it. That's a reason, nothing. But anyhow, and he did great. What are the causes of erectile dysfunction? If you've been to my office and we've sat down and we've talked about it, I normally draw this diagram because there are a ton of reasons why men may experience erectile dysfunction. A large population of them have high blood pressure, vascular disease, something else, to where the arteries don't dilate well enough to deliver blood to the penis. As a matter of fact, they were saying a few years back that men that presented with erectile dysfunction or had ED with no cardiac history, maybe you need to send them to get a cardiac evaluation as well. We're still not there. There's no clear-cut guideline to send them over there, but we see a lot of guys with vascular issues, and that's one of the questions I do ask, is how long have you had high blood pressure, kind of what medications you take, because medications also can cause it in about 15% of men. Diabetes. Diabetes is the great equalizer. I mean, I tell you, it causes everything, and this is just one of them there. I also find out how long you've had diabetes. What are the hemoglobin A1C values doing? And I've done a lot of ED treatment for about the past 10 years, and one of the things we'll talk about are implants for erectile dysfunction. And I've had so many diabetics come through there, and I tell them, look, your hemoglobin A1C needs to be less than 8 before I'll do an implant, because the risk of infection just goes up astronomically as you get close to 10. And hemoglobin A1C is the percent of glycosylated hemoglobin. The higher that number, the worse their diabetes control is. And I tell you, some of these men are motivated because they'll get that number down to 6.5, 7. It usually takes about 3 months, but they'll get it down right away. So again, spinal cord injury, pelvic trauma, medications, some endocrine problems, low testosterone. I do see guys with low testosterone that have some erectile issues. I have to be careful about that. Because some of the insurance companies get a little picky when it comes to treating low T, even though one of the added benefits from it sometimes are that the erections pick up, et cetera. But we kind of have to skirt around that one a little bit. And there is hope for erection restoration. I mean, again, just because it doesn't work now doesn't mean it's not going to. And again, there are treatment options. I do tell people that one of the first things they need to do is talk to their spouse. Got a lot of men that come in and they feel guilty. They're just really down on themselves. They're probably way too hard on themselves than they should be. But, tell them to talk to the spouse. Make sure what we're doing is it's good for both of them there. I do have some men that come in, they want to get it done, and the wife's like, I'm not interested. And I'm like, that's a conversation y'all probably can have in the parking lot. We started with Viagra. That's one of the first treatment lines I go down, Viagra or Cialis. This medication is probably the most well-known trademarked item in the world. You can go anywhere in the world and say little blue pill, and they'll tell you what it is. Matter of fact, I went to Ireland 2 years ago, and that's where they're headquartered at, Pfizer did. And that's another topic when we start talking about drug companies and having to move overseas and all this other stuff. But Viagra was initially a pulmonary hypertension medication. And they started seeing improved erections in their test patients and said, wow, we finally hit on gold here. Because at that point in time, there was very little on the market that you could do for erectile dysfunction. These work in response to stimulation. It takes about an hour before they start working. The Viagra usually works about 4 hours. Cialis is a little bit different. It's a longer acting one. You take one a day, and I recommend that you take it on an empty stomach. So if you're doing Viagra, try not to eat 2 or 3 hours before you take it. If you're taking Cialis daily, I recommend getting up first thing in the morning, taking it on an empty stomach, and I think you'll get better results. And I changed my whole treatment plan up about 5 years ago and started seeing that it seemed to work better that way. Unfortunately, there's a lot of side effects with anything. Headache, facial flushing, that's usually the Viagra. Cialis can cause low back pain, leg pain, etc. Upset stomach, some dizziness. You can't take it with nitrates. So guys that come in and they're on some nitrates for blood pressure, or If they have nitroglycerin for chest pain, I recommend staying away from this medication. Just because if you do start having chest pain and you've taken one, it can cause an unsafe drop in your blood pressure and you can have a heart attack and die. Again, if you start taking things for your prostate to make you pee, usually you want to get stable on that medication. And if you got a weak heart, bad heart, whatever else, you may want to not use these medicines. Again, there are a lot of devices that we use. The vacuum erection devices, I don't know if they've taken out my pictures on all these or not. Intraurethral suppositories, we have self-injections, and penile implants or penile prostheses. Okay, these have been taken out. Unfortunately, I had a lot of slides that would actually show you the way to use these. Vacuum erection device it's a neat device. I do recommend men that have had, say, prostate cancer and treatment and they've had erectile dysfunction. It's a good conditioning device because down in Miami they did a study back in the 90s that actually demonstrated that men who were undergoing radical prostatectomy, those that developed erectile dysfunction afterwards, had shrinkage of the penis anywhere from 0.5 centimeter up to like 4 centimeters within the first year. So the vacuum erection device is a good device to help for conditioning, to gain length back and such. It was actually invented in Georgia, and Julian Osmond, he started a company in Augusta Medical Systems. And there's some back and forth whether he found this kind of idea. He was working with a guy that worked with a traveling circus, a carny or something or whatever else. But Julian went in his shop behind the house and got some PVC pipe and suction tubing. And next thing you know is he comes out with a vacuum erection device. It's a good device for conditioning. Probably not the best device. But it's, dollar for dollar is one of the cheapest ones out there. It can cause some bruising. You have to use a band with it. It can cause a cold erection, things like that. Intraurethral suppositories. These are little gelatin pellets you stick in the head of the penis, the urine channel, and it diffuses a vasodilator. I had a nice set of slides here that actually talked about the physiology of erections. Because what ends up happening initially is the smooth muscle in the penis, it dilates and it allows blood to rush in. Then you get arterial dilatation, and then there's some veins that get compressed to hold the blood in there. And then you get a rise in your blood pressure, and a little bit more blood's pushed in there right before orgasm. And then it detumesces afterwards, and the smooth muscle actually in the penis pushes out all the blood. But the intraurethral suppositories work by vasodilation. The problem I found with them are that they don't work well. They can cause some stinging when you put them in there. They're expensive. So a few issues with that. Self-injections, we do a lot of that. I've done it because it's probably one of the cheaper things out there. And in men that did not respond to Viagra, or they found that the vacuum erection device was just a little too painful, they did pretty well with the self-injections, where you actually put a compounded formula that's all vasodilators into the penis, and it causes relaxation of smooth muscle, arterial dilatation, blood flow to rush in there. The only problems that you really see with this are some scarring over time using it. And I've had a handful of men that, you've heard the commercial, if you've had an erection lasting longer than 4 hours, you need to call your physician. And most men laugh at me and they say, "Doc, first person I'm calling is my neighbor." That's not the case. I guarantee you, if it's hard that long, I'm the first person they call, and they come in struggling. So that's one of the kind of downsides of it. We do a lot of penile implants. I've done about 500 implants. Was one of the top implanters at my private practice before I came down here. It is a surgical procedure. So, we have to evaluate you not only for surgery, but also perioperatively make sure if you're diabetic that your diabetes is well controlled. We give you antibiotics. And there's a couple of different types of implants, from ones that stay rigid and hard all the time to ones you pump up, and it's all self-contained within the body. So unless somebody's touching it or whatever, it looks normal. So I had some nice slides here again that were edited out. Too many penis pictures, sorry. So I have to say it more times. So again, you know, I'm not here to beat folks down. You know, live life to the fullest. I mean, there's no guarantees in life, you know. There is a quantity versus quality of life as well that we have to be cognizant of. Everything in moderation. I mean, you know, don't be like the guy that, you know, takes a couple of the Viagra in a day and knowing you should only take it once a day. I had one guy that was from Jacksonville, Florida, that gave himself multiple shots in a day and had issues after that. Everything in moderation. If you're drinking a 12-pack of Mountain Dews a day and you have kidney stones, you want to cut back a little bit. Don't believe everything you hear. Google MD is one of the things we battle all the time as physicians, and there's a lot of good information out there, but there's a lot of misinformation as well. Get preventative maintenance. It's easy, it's quick. I tell a lot of jokes if you come in to see me, because I'm not here to scold you or anything. I was raised Southern Baptist. I knew what it was when the preacher got up there and beat on the Bible and all that, and I ain't here to do that to folks when they come in. I want to facilitate your care. I don't scold folks, I just give you options. And things are going to happen, but yeah, the great thing is we've got treatment options. And some things are just easy fixes. You know, if you ain't peeing well, you know, get checked out. It may be something as simple as putting you on a $4 prescription that you may not pay anything for, but it improves your quality of life. You're not getting up to pee at night, your stream's great or whatever else, to, hey, you know, I've had erectile dysfunction, but we can try this and things are great. You know, I rarely see couples fight that have a healthy sex life. Rarely see them fight. So, you know, we got treatment options and everything there. Oh, let me click off this. And then last but not least, I'm Dr. Burnette. I'm the one on the top. I work with Dr. Grayson. He's my partner. And then we have a PA coming in a couple of months. Fran Johnson, who's a great girl. She's from South Georgia. Her dad was a cardiothoracic surgeon in Macon and now is in Valdosta, but they grew up over in Hayhira. And she's going to be a great addition. We're at 116 Mimosa. If you don't know where that's at, it's right across from the entrance to the ER. So we look forward to seeing. I see a lot of friendly faces here. If you got any questions or concerns, give us a call. Thanks. Yeah.
You had a picture of Lance Armstrong, the bicycle rider.
Yeah.
Are the problems with riding a bicycle that made of your...
You know, they have done some nerve conduction studies. Again, a lot of guys that do competitive cycling try to get bicycle seats that maybe don't push up so much on the perineum to cause nerve injury. Some of the guys do end up developing paresthesias, numbness down there, erectile dysfunction. I don't think his testis cancer was caused necessarily by riding a bicycle. It's just something that happened. And again, testis tumors, typically you see them more common in white males. But there are a number of things that can specifically cause, especially those guys that ride for hundreds of miles at a time. So, yeah. Yep.
If you are diagnosed with prostate cancer, what is the prognosis and treatment?
Yeah, that's a good question. So the prognosis all depends on the type of prostate cancer. Again, when you talk about prostate cancer, it's a spectrum of cancers. Normally, one of the first things I tell guys, you know, this is kind of my canned talk there, but you know, nobody ever falls off a turnip truck hardly in front of your office and says, I got prostate cancer. There's a process that you go by where you have an elevated PSA value, you undergo a biopsy, and the pathologist looks under a microscope to see how aggressive the cancer looks. And based on aggressiveness, they give it a score, and it's called a Gleason score. Used to, we scored it 1 to 5. Now we score it 3, 4, and 5, with 3 being the most benign form and 5 being the most aggressive. And 4, it's kind of the wild card. Sometimes it can be slow, sometimes it can be quick. So based on what type of cancer you got or you have, really is going to depend on A, how aggressive you need to treat this, and B, your life expectancy. Now, if you look at a guy that's a run-of-the-mill Gleason grade 3+3, and again, you can have mixtures of different patterns. For low volume, and again, low grade cancer, we offer everything from active surveillance, where we watch PSA values with the plans on repeating a biopsy in 12 to 18 months. We do a digital rectal exam every 6 months, and we just watch it. We don't even treat it. If you look at a Memorial Sloan Kettering nomogram based off a run-of-the-mill 55-year-old man with a couple of cores of Gleason grade 3+3, a PSA value less than 10, around the 4 range, and you put all of his data into one of these nomograms, there's about a 65% chance all the cancer is contained in the prostate gland, 1% chance he's had nodal spread. The 10 and 15 year survival, if he underwent a prostatectomy, is 99% for each. So survival rates are almost 100%. I don't think you get that anywhere. So again, the treatment would vary from active surveillance, again, just watching, to say somebody had a little more aggressive type of cancer, a 4+3, and a young man, you may want to talk to him about surgical removal of the prostate gland. Now, the prostate gland is part of the male reproductive system. It produces the fluid when you have an orgasm. Also, the nerves that cause an orgasm or an erection run right there beside it, so they're frequently damaged during surgery or after radiation therapy. So he could surgically remove it, but he'd have the side effects possibly of some urine leakage and also erectile dysfunction. And another treatment option is radiation therapy, and that comes in 2 forms. You have external beam radiation therapy, where you go every day for 15 minutes, they zap your pelvis, and they kill the cancer. There's also a radiation method where we go inside out, where we put radioactive seeds into the prostate gland, and the seeds radiate you from the inside out. And there's combination of the 2. So again, if you do see a man that comes in though, and he has a PSA value, and I've seen a guy come in, PSA value was 600. He had Gleason grade 10, 5+5. He had a poorly differentiated cancer. It was very aggressive. It had already metastasized, and the average life expectancy is anywhere from 9 to 15 months. So that's kind of the difference there. But yeah, it really is, to me, it's kind of specific to not only the type of cancer, but how advanced, level of PSA values, all that. Yeah. Next question. Got one burning question out there. Camera guy? No? All right. Well, thank you all. Thank you all, and y'all have a good evening.